Want to talk about technology for a moment in terms of how it'll help the hospital system kind of, again, find efficiencies. I'm curious from your standpoint, having been, worked in hospitals and also just been an administrator, what technological advancement over the last 5 years in healthcare are you most impressed by, and where do you hope to expand the use of technology within the HHC system?
One thing is, as a nation, right, especially the baby boomer, we are all living longer and longer. I can tell you that. As a baby boomer myself, I have no intention of dying, right? I will probably live till 95, 98. I will extract every dollar of Medicare from you before I eventually die, right? So that's what I'm a baby boomer. That's what I'm supposed to do. I'm not supposed to die. So now, because of that, and more insured people coming in, there's a capacity issue. So we suddenly have a large number of people who either living longer or new people coming into the system to the healthcare. Suddenly, they don't have enough capacity of physicians, nurses, physician assistants, nurse practitioners, other folks to be able to do that. So the only way, how can we take care of a large number of people with a limited number of capacity, is the telemedicine, teleradiology, teleconsults, right? That is one area which I am extremely excited about. So that the idea of ability to manage the care of a large portion of population using effective technology so that we can compensate for the lack of capacity to take care of the more number of people who need care as a part of it. So we have really done telemedicine, teleradiology for diabetic patients through our health and home care in the past. We found it to be very effective. When we found diabetics who are not able to control their diabetic status, when they did teleradiology, and the telemedicine concept, we were able to manage the diabetes much better. So I think the technology is going to be extremely helpful in getting those areas where we are able to reach more people, right, through the technology as opposed to traveling from place to place. I can tell you, as I was a surgeon practicing for 20 years. I practiced in 6 different hospitals. The amount of time I spent traveling from hospital to hospital, a good portion of my time is gone, which is not good anymore. So I think the world is coming closer and closer because of technology, and technology is probably going to take care of our capacity issue into the future. So I am excited about it. I think that's a great area for us to do that. Of course, we have Watson. We don't need doctors anymore. You go to Watson and tell them, Watson, I have chest pain. What do you think? Watson will tell you, you have a heart attack, go to the hospital, and then that's the end of it. Thank you.
We're going to open it up to questions from the audience. We can have time for a couple if there's anybody.
Hi, my name is Makran. My question is about the healthcare system connecting back to the municipal and the state system. This is with reference to, having rats and cockroaches and their impact on the health. But at the same time, when we have a disaster like, the heat wave in Chicago or the Hurricane Sandy and some of the epidemics which follows.
Now, if I understand the question, you're talking about the role of healthcare system in those natural and disasters and also the cleanliness? It depends on different things. In New York City, we have a commissioner for public health, right? A commissioner for health and mental hygiene. There's a commissioner. Whereas in Chicago and Denver, other places, when I was in Chicago, I was also the commissioner for health for Cook County, right? Not Chicago area, but Cook County, because that fall under the provider system as a part of it. the public health department and the public hospital systems, if they're not one of them, they need to work together very, very closely. Because the population health, to a great extent, depends on working with the public health departments in the city where your public hospital system is. So we have a great working relationship with Dr. Bassett, who is our commissioner, who shares a lot of my vision of what we want to do there. I share a lot of our thoughts and ideas. So it is a good working relationship to do that. So the point is, you're right. In the past, the healthcare system basically had one principle, right? You come to the door, you are my patient. The minute you leave the door, I don't want to know anything about you. Still next time you come back to me, right? I'm only responsible when you're inside my system. Otherwise, we're not. But the population health basically says the hospital extends beyond the four walls of a building, right? In other words, the hospital has got no walls, right? So if you really wanted to be an effective population manager, then you got to work with the public health departments in your city or in a municipality, right? That's what it is. So we have changed ourselves, right? We are really, now we say that if I'm also responsible for care in between your visits. You come to me with the high blood pressure, and in the past, I used to give you medicine. I will see you in 6 months. Unless you call me during the 6 months, I don't want to know anything about you. But now we ask you the next day, do you take the medication? Do you take the blood pressure? You have telemedicine, giving me your blood pressure, and you're out of blood pressure. Our nurse calls you and said, what happened to you, right? So we are really not only responsible during your visit, you are also responsible in between the visits. Now we are going to the next level of population health. That means you are also my responsibility, even though you never came to my system. You are not my patient, you never came into my system, but you live in the neighborhood and zip code, you are my responsibility. That's the population health, right? So those are some of the areas where we have to really move into that, because we moved away from a monolithic, four-walled hospital system to the communities, to community of our patients. Now we need to get into community of everybody, your patients and not your patients, and also the future patients of yours.
In the back.
Yes, hi. It's Elizabeth Lynham from the Citizens Budget Commission. You spoke about HHC's role in caring for the uninsured and the fact that the ACA has, in all likelihood, left a fairly large population of uninsured, undocumented immigrants who aren't eligible. I'm wondering, sort of a two-part question. One, the funding for that is dwindling. As you mentioned, the federal government is changing around some of the funding formulas, assuming that more of the population will be uninsured. And there were a series of cuts in some of the supplemental funding that were planned and have been postponed once by the federal government. And then the second part of it is, within your mandate as a city agency, or at least given a mandate by the city to care for this uninsured population, what is the kind of correct financial role, or if you could just design the financial role with New York City that you would like, what would that look like for you to continue to finance the care for the uninsured going forward? And what prospects do you see with the federal government for trying to work? I assume there are other large cities that would have this similar population problem with the ineligible for the ACA folks. So I'm wondering, sort of, that's a two-part around the federal expectation and then what you would do to design the proper rational role with New York City government financially.
It's a great question. So let's answer it again in two ways. One, we need to create a social, moral platform why we need to take care of uninsured population. Because that has been a contentious political debate in our country, right? Because why do we have to take care of them, right? They are here illegally, they should not be part of it, right? So let's take that argument first. In an urban society, your health depends on my health depends on your health. Because I'm sitting next to you in the subway, or I go and eat in a restaurant, the person who cooks my food, I have an absolute personal interest to make sure that he or she is in good health. Otherwise, I'm going home sick, right? So this concept somehow that these undocumented, uninsured people are somewhere living in this side of the city and everybody else living on this side of the city, it is myth. So we are all together. We are actually living on top of each other, right? So it is a moral and a business imperative to make sure that everybody is healthy. Otherwise, you can never make the whole system healthy, right? The whole population healthy. So having decided that, if we agree that there is a business imperative, a moral imperative to keep everybody healthy, then the question comes in, how do you fund for it? How do you fund it? There are very innovative ways people have done that, right? A lot of places, for example, an example is the Voice of Detroit initiative, right? VODI. This initiative started in Detroit, and they basically figured out how to care coordinate uninsured people. When they did that, the overall cost of charity care started going down. Because by managing them better, as I said before when I was the first question, I said, by managing them better and not getting them into a very expensive inpatient ED care, you actually save money, right? And that concept has not really sunk into the people very, very much as a part of it. So, not funding the healthcare of uninsured or undocumented people is really a political issue, not really a financial issue. Because at the end of the day, for the same amount of undocumented, uninsured people, you're going to spend money. The question is whether you want to spend money here, which is cheaper, or you're going to spend money here, which is going to be 10 times more expensive. So it's not about not spending the money. I think it is, some of people is invisible to people that we are paying for that care. If the person comes to emergency department with a significant medical issue, undocumented, uninsured, we're still going to take care of them. And every hospital here takes care of them. And what they do is they do the cost shifting by getting more commercial patients and they get a better rate from commercial, and you cost shift into this. When you raise the rate of the commercial insurance, your premium goes up. So you eventually pay for it one way or another. So I hope that federal government understands it, and they probably put some of those on the state government and the city, able to figure out how to get the uninsured connected to care by a program, which I believe will be much, much cheaper. Because one of the things we did in Chicago was this, right? After the ACA was implemented, the Cook County had got about 190,000 people who were uninsured, right? We went around and added all the charity care given by all the hospitals in Chicago. It was total about $318 million. That's what they claimed in their ICRs. $318 million taking care of 190,000 people. I can take care of 190,000 people half the money. Because the problem why it is because since you don't have a coordinated structure for them, they go down to hospital A for a headache on Wednesday, get a CAT scan. They go to hospital B on Thursday and get another CAT scan for the headache. And then they go to the hospital C on Friday night and get a CAT scan for the head. Because the care is not coordinated. And every hospital writes off as a charity X amount of dollars. So we as responsible citizens need to explain this. How do you do that? One, it is better to keep them healthy, otherwise I'm going to get sick. Two, having decided that it's better to really care coordinate them also instead of them actually rising up the prices. So I think both financially and socially it is so important that we need to articulate this to people. There is nothing called charity care. The tax-paying people of this country pay for it one way or another, right? There is no way. I cannot give charity care. I promise you, I have no way I am printing any dollars in my basement, right? All the dollars I've spent on my charity care is given by government, which in turn given by the taxpayers of this country. So I think we have to really do a much better articulation of that, much better communication of that as a part of it, right? And we kind of not done a good job of it.
All right, let's give I'm sorry, we have one more.
Hi, my name is Donna Panton. You said two things. You said you want to live to be 98, and you also said that you're looking at leveraging the size of HHC for various improvements, budgetary and otherwise. Now, given two things, a New York Times article last week about this poor man who wanted to die at home and was given horrible runaround in the healthcare, the nursing home industry, and also Dr. Ezekiel Emanuel's article in Atlantic about not living past 75. Has HHC thought of leveraging in that direction? You talk a lot about, getting people before they're sick. There's preventive care, community health centers. What about the other side of life?
I know. I think Ezekiel himself got himself into deep trouble by that, right? By saying that, because almost half the nation poured up and said, this is what Sarah Palin talking about, deathbeds. Now Ezekiel is saying that you can only live till 76 and after that you have nothing else for you, right? No, but having said that, we have invested a lot in palliative care. Every one of our hospitals has got a palliative care division. Because I believe fundamentally that people, if you decide to die with respect, we should give them that cost. You're right. What happened in the New York Times article is absolutely, I was moved by that. It brought tears to my eyes. What happens in a system like this, where people lost their right just because they got sick? You cannot have that. You don't lose your right just because you're sick. You don't lose your right just because you're old. Those are fundamentally bigger problem for us, right? So you're right. We have done a good job in our country, right? We sold the rescue medicine very, very well. We know how to rescue people from a deathbed, but we don't know how to keep people healthy, right? We excelled in rescue medicine, and we sold it to the rest of the world that this is the best healthcare model. And I always used to say this. We as Americans, we die the most expensive death than anybody else. What is spent on us in the last week of our death is more than what we have spent on the entire lifetime on the healthcare. So we are not good at healthcare. We are extremely good at rescue care. We know how to rescue, and that's what it's all about, right? In fact, we talked about it extensively. I got myself in trouble when I said that. We have a culture of celebration of sick care. We get up and say, my cardiologist is the best cardiologist in the city because he done 1,000 stents last year. We should say, why your cardiologist doing 1,000 stents? That means he failed 1,000 people during the primary care. That's why he ended up with stents in the first place, right? Why do we not do that, right? We have to really, every ED preventable admission, every ED visits, every preventable admission should not be looked upon as a profitable service line. It should be looked upon as a failure of primary care system in this country, right? So I think we need to know how to practice healthcare, and we need to know how to respect people. We need to make sure that just because we're a healthcare provider, it does not give us a right to take away somebody else's rights. And if people want to die a dignified death, we should make that happen. So we have to go a very long way from a very paternalistic healthcare delivery system into a system which really takes into people's concerns and the wishes in mind and able to respect them. And I agree with you. And by the way, I said 95 years old as a baby boomer is not my choice. That's what baby boomers do to you. So I don't know what to do with that. So.
Let's give Dr. Raju a round of applause.